Can everyone see my slides?
Yeah.
All right, perfect. Okay, so good morning again, everybody. For those of you who don't know me, my name is Thomas Metzner. I'm one of the urology residents here at UF Jacksonville, and welcome to Grand Rounds. And this morning's topic is on reconstructive urology, and it goes by the title of Recon Potpourri. And if any of you are Jeopardy fans, like I am, you'll know that potpourri is historically used on Jeopardy to describe kind of a smattering of subjects, sort of a mixture of subjects. And reconstructive urology is obviously a very broad subject. And so I'm going to touch on a few topics today, kind of a mixture of things, and sort of take a very wide angled view of some of these recon topics as kind of a rudimentary or introductory aspect of these operations. And the impetus for this is that while I've been on service, I have encountered some patients who have had prior recon procedures, or I've been called into intraoperative consults for patients who may require a recon procedure. And so understanding some of these operations and what exactly is possible in the world of reconstructive urology is kind of the overarching theme and goal for this talk this morning. Before we get started, I don't have any disclosures. And this is going to be our agenda. We're going to discuss different techniques and considerations to address the following aspects of reconstructive urology: ureteral injury, bladder augmentation, and urinary diversion. We'll have a little summary at the end, and hopefully we'll have some time for some questions and some discussion. So first, we're going to start with a little intro to ureteral injury. And ureteral injury is graded. This is from the American Association for Surgery of Trauma. And it's graded 1 through 5, with grade 1 being the least complex, with grade 5 injuries being the most complex. Causes of ureteral injury can be blunt and or penetrating trauma. And then commonly what we get called about also is iatrogenic injury, unfortunately, oftentimes from other types of surgery, colorectal surgery, gynecologic surgery, some aspects of general and vascular surgery can precipitate an unintentional ureteral injury. And we often get called to those to assist. And as you can see from this chart, grade 1 and 2 ureteral injuries can oftentimes be managed rather conservatively with oftentimes a stent or some type of urinary drainage. But when we start looking at grades 3 through 5 injuries, this is where surgical reconstruction is likely going to come into play. And the repair of these injuries is often predicated upon a number of factors. One is the location of the injury with relation to the ureter. Is it proximal? Is it distal? Or is it within the mid-ureter? The size of the injury, that is the length of the ureter that is involved. Also importantly to consider is the size of the bladder, as well as its function and its relative mobility. A prior history of radiation could impact how we choose to repair a ureter. And then the function of the patient's kidney, as well as the presence of the contralateral renal unit, or if this is a solitary renal unit, can also influence how we go about fixing these. So there are some principles of ureteral reconstruction that are really important to keep in mind when we're approaching these types of operations. And one of those, the first one, is to understand the anatomy of the ureter and the blood supply therein. And what I mean by that is that the blood supply of the ureter, fortunately for us, it has an extensive blood supply with various vessels that arise from some larger vessels that are more midline structures. And then, and this is predominantly in the proximal 2/3 of the ureter. And then in the distal third of the ureter, the branches that supply the ureter are going to arise from vessels that are more in a lateral position. And the reason it's important to keep this in mind is because if we need to mobilize this ureter, we obviously want to mobilize it towards its blood supply to ensure that it has adequate vascularization. And it's also important to remember that if we need to debride the ureter, we may need to do so in the interest of removing segments that are otherwise devascularized because of an injury. And that's exactly what's being depicted in this image to the right, is this kind of ratty looking ureter with its various, its two injured ends is essentially being removed and then reanastomosed. And then, of course, along with all surgical principles, anytime we anastomose something, we want to minimize tension, and the ureter is no different. And so we're going to want to choose techniques that keep the anastomosis as tension-free as possible. So first way that we can think about repairing a ureter is just by doing a ureterostomy. And so this is a repair that's done for a short ureteral injury, and it's an anastomosis of the ureter to itself with proper debridement of any injured aspect of the ureter. And these are done for short injuries. And there's a variety of techniques that can be utilized to perform the anastomosis, and that's what's being depicted here: spatulation, and then essentially just performing an anastomosis and trying to do so in a way that maximizes the ureteral lumen and prevents stricture. Next is a ureterocalycostomy. And so this involves essentially amputation of the lower pole of the ureter, or excuse me, of the kidney, and then anastomosis of the ureter to a lower pole calyx. And indications for this type of repair would be a UPJ obstruction, as well as a UPJ obstruction that is after a pyeloplasty, so the patient didn't respond well to a pyeloplasty. Upper ureteral strictures, an obstructing stone in the UPJ, and then I hesitate to use the A word as somebody who is about to perform ureteroscopy in a couple hours and do a stone procedure, but avulsion is the dreaded injury that can befall some unfortunate urologists. And if that is the case, then we may want to think about doing a ureterocalycostomy. Not surprisingly, there are complications that can arise from this. Recurrent infections occurs in up to 30% of patients, as well as hemorrhage. Hemostasis is going to be a big part of doing this operation. And because this operation is often done in patients who are obstructed, unfortunately, the literature is done in a lot of patients who have what is described as a thin renal parenchyma. And so oftentimes hemorrhage is not a huge concern in those types of kidneys because of this thin parenchyma. However, in an otherwise robust kidney, this may be more of a problem. And so hemostasis can often be obtained with sutural ligation. The use of a harmonic device to incise and perform that amputation has also been described in the literature as a means of obtaining that hemostasis. And then recurrent stricture can also occur in these patients and is something to keep in mind. The next technique is a transureterostomy. So this involves mobilization of one ureter to anastomose to the contralateral ureter. And this can be used when primary anastomosis or ureteroneocystotomy is not feasible. It's also an option for patients who unfortunately sustain a more extensive injury. So these can be patients who have a concomitant rectal injury or perhaps a bladder injury, as well as patients who have been irradiated. And so this may be an instance in which we don't want to do a ureteroneocystotomy. We would rather plug in that ureter into the contralateral ureter. And that's exactly what's being depicted here in this image to the right. And the contralateral ureter is passed through a mesenteric window in order to be retroperitonealized to the other side, essentially, and then anastomosed. And there are a variety of techniques that can be done. And this is, I think, a side anastomosis is the way that this was described. Complications that can arise from this procedure. I found a study mentioned from Owasco et al. Published in 2010. It involved a small number of patients, relatively 56 patients. 9.5% of them had a urinary leak. That was the complication that arose the most. Overall, 24% of the cohort had some type of complication, and 10% of the patients needed some type of revision or reoperation, presumably because either a leak that failed or stricture. The next procedure is a ureteroneocystotomy. So this is ureteral reimplantation into the bladder. And this can be done in either refluxing or non-refluxing fashion. The figure to the right here is depicting a non-refluxing ureteroneocystotomy. And so the bladder is incised, and then a tunnel is made in a submucosal tunnel is made, and then that ureter is anastomosed into that tunnel, and the bladder is closed. The adult indications for this are a ureteral injury occurring in the distal ureter, and typically these are limited to injuries that are about 3 to 4 centimeters distal. So more extensive injuries that occur higher up probably are not going to be able to achieve our tension-free anastomosis. And this technique was developed for initially kind of described more in children, and that's why there is this non-refluxing option. And the refluxing option is essentially used for adults and can be performed with modifications of what you are seeing here to the right. And studies have indicated that there's not a huge difference in adult patients, at least, whether you perform it non-refluxing or refluxing. They don't have a huge impact on their renal function. Importantly to remember, the reimplantation is done medial to the orthotopic ureteral orifice, and this is so that the ureter does not become kinked by trying to do the anastomosis lateral. There's a chance that you can actually inadvertently kind of precipitate an angle to the ureter that may cause it to kink. And for larger defects, this can be performed concomitantly with a Potpourri flap or a psoas hitch. And so this is a Potpourri flap, and it's used to gain length for distal ureteral injuries. The anterior aspect of the ureter, or excuse me, of the bladder is incised, and then a flap is created. And this flap is tubularized, and the ureter is anastomosed into that flap, and then the bladder and the tubularized flap are closed. And the flap must be longer than the measured distance that's estimated to be required for the ureteral injury due to contracture of that tubularized aspect of the bladder once the anastomosis is performed. And that's what's being depicted here to the right, obviously. And then this is another figure that I just liked a lot, that I thought showed it really well. And here is that anterior kind of flap being raised, and then it's tubularized and everything is closed back together. And then this ureter that is injured a little more to proximal area can be reanastomosed with a little less tension. A psoas hitch is also utilized to gain length and distance to achieve that tension-free anastomosis. And for this procedure, this involves a cephalad fixation of the bladder to the iliopsoas tendon to reapproximate the bladder and the shortened ureter. Prerequisites for performing the psoas hitch are that the patient should have good bladder capacity and compliance, and patients who have been previously irradiated in the pelvis are not going to be good candidates for this. The bladder is incised longitudinally, and then a hand or a retractor is placed into the bladder, and the bladder is pushed up towards the patient's head. And then the posterior bladder is affixed typically above the iliac bifurcation, utilizing superficial and longitudinal non-absorbable sutures. And the reason that care needs to be taken to take the suture bites in a very superficial manner and done longitudinally is to avoid injury to the femoral and the genitofemoral nerves that run along the psoas. The contralateral pedicle of the bladder can also be ligated. That's ligation of the superior visceral artery in order to provide more length and mobility for the bladder. And then, of course, a ureteroneocystotomy is performed. And occasionally, a Potpourri flap can also be utilized at the same time in order to gain more length on that ureter. So that's kind of utilizing native urologic tissues in order to perform these repairs. But we can also use other tissues from other organs to facilitate repair of more extensive ureteral injuries as well. And so the first one I want to talk about is a buccal mucosal graft ureteroplasty. So buccal mucosa is an excellent source for grafting tissues in a moist environment. It's typically used for ureteral stricture disease. That is a stricture of the ureter that tends to be rather extensive. And the buccal mucosa is harvested from the inner cheek of the patient. Preparation of the mouth is performed along with preparation of the patient's abdomen. And strategic placement of the endotracheal tube is also critical in surgical planning and essentially setting up the room. And then also, care must be given to avoid Stenson's duct or the parotid duct. And this is the anatomical location of that duct in the cheek. So we would want to be away from that, typically below that opening to that duct to avoid compromising it. And so this is a buccal mucosal graft, kind of step-by-step ureteroplasty. And this was actually performed robotically. And so imaging is utilized to delineate the stricture, and that's what's being depicted here in A. And then an RPG was also used to kind of estimate the length of that stricture. The graft is then harvested from the mouth, and it is sewn onto an open segment of that ureter over a stent as an onlay graft. And then omentum can be wrapped around the graft site in order to assist with neovascularization and kind of as a means of reinforcing that graft and essentially helping it to take. And so here on the bottom right is imaging from this patient that was performed, I think the paper said about a year after, and it showed this patent ureter indicating that the graft had taken rather nicely. And then in addition to the buccal graft, we can also contemplate utilizing bowel as a means of ureteral replacement, specifically ileal tissue as a means of ureteral replacement. And so when we utilize the ileum, typically the distal ileum is used and the terminal ileum is avoided in order to avoid issues with absorbing B12 and B12 deficiency. Of course, anytime we utilize bowel, this can potentially invite possible metabolic derangements from reabsorption complications. And also the patient can have bowel complications like ileus and potential leak. And so really the use of ileal tissue as a ureteral replacement tends to be kind of a last resort technique when other types of ureteral repair or mobilization of the bladder really isn't very feasible or possible. And ileal ureteral replacement comes essentially in two flavors. So one is an isoperistaltic technique, and the other is a Yang-Monti technique. And there is a study from Arbanis et al. That took a look at 91 patients with a 36-month follow-up. They had a stricture rate of 3% and a fistula rate of 7%. But in 75% of their patients, patients maintained a stable or improved creatinine, indicating that this seems to be a pretty robust procedure when it is performed by skilled surgeons, and this can really generate a lasting response to these types of injuries. And so this is an isoperistaltic ileal segment, and isoperistaltic means the peristalsis of the bowel segment that it's utilized is in the same direction of the flow of urine. So it's essentially peristalting from the kidney down to the bladder. And this bowel segment is the blood supply of that bowel segment is maintained with the mesentery maintained. It's passed through a mesenteric window to retroperitonealize that bowel segment, and then it is anastomosed first at the UPJ, essentially with a spatulated UPJ, and then it is anastomosed on the lower end at the bladder. And so that's one means of performing the ilio-ureteral replacement. The other is the Yang-Monti. And so with the Yang-Monti approach, a segment of bowel is maintained again on its mesenteric pedicle, and then it's essentially separated into three segments, and those three segments of bowel are retubularized into a segment that is more narrow than the bowel itself, and that's to, again, gain length. And then that retubularization is performed over a ureteral stent, and the ends are anastomosed to the segments of the ureter and or the bladder in order to obtain that tension-free anastomosis. So that kind of concludes our initial discussion of ureteral repair. And now I want to move on to operations that involve the bladder, those being augmentation and diversion. And so augmentation of the bladder is enlargement of the urinary bladder utilizing tissue from a separate organ, whereas diversion is rerouting of the flow of urine to bypass a diseased portion of the urinary tract, typically the bladder or the urethra. And these diversions can be continent or incontinent. And speaking of urinary diversion, this tall gentleman in the hat right here is me. And this is me performing my first ileal conduit with the rest of the fellows here on a radical cystectomy. So this is my first urinary diversion, I suppose, or contributing to it as a resident. And so this was a great day for me. I think I was anastomosing ureters into the conduit here. Shout out to Dr. Kresh, who got this picture. All right, so indications for these procedures. An augmentation is typically done to increase the bladder size to reduce the pressure of that bladder, as well as improve continence and prevent the reflux of urine that can lead to renal injury. So oftentimes these are performed in patients who have spinal dysraphism, i.e. spina bifida, potential congenital malformations of the bladder, like patients with cloacal dextrophy or bladder extrophy, as well as patients who just generally have a low volume or low capacity bladder. Diversion is typically done as part of as an operation due to urinary tract disease and or missing aspects of the urinary tract that are removed because of disease. So this could be from lower tract trauma. It can also be from malignancy, such as urothelial carcinoma or pelvic sarcoma, and also for patients who have had prior irradiation. So we'll talk about types of augmentations. Various types of tissues can be utilized to augment the bladder. Historically, stomach has been utilized. However, this tends to be avoided now due to hematuria dysuria syndrome, and this can produce a hypochloremic and hypokalemic metabolic alkalosis and respiratory distress. So stomach typically isn't utilized anymore. You can also utilize segments of ureter. This would be ureterocystoplasty, excuse me. And then you can also use segments of bowel. And typically ileum seems to be the choice that's predominantly described in the literature now. And in order to perform this procedure, the bladder is essentially clamshelled, and then the aforementioned tissue is sewn onto it. And so here is a depiction of that. This is an ileocystoplasty. So it utilizes a 20 to 40 centimeter segment of ileum that is 15 to 20 centimeters proximal to the ileocecal valve. The mesentery is maintained, of course, and it is approximated to the bladder. And then that segment of bowel is opened on the antimesenteric border, and it's detubularized and folded into kind of this patch sort of shape. And then it is sewn onto the bladder that, as I mentioned, is kind of clamshelled open, utilizing absorbable sutures and this is described as a sagittal bivalve. So this is kind of how that is done. It seems to be that ileum is the popular tissue to use now. Moving on to diversions. There are many varieties of urinary diversions. Some use the native bladder for storage of the urine, and this is essentially a vesicostomy. Others are incontinent urinary diversions that, just as they sound, they are incapable of storing urine. So these are typically ileal conduits. And then there are continent forms of urinary diversion that are able to store the urine, and then the patient empties that diversion when so desired. And this can be done through a continent cutaneous diversion, where a patient catheterizes in order to empty the diversion, or it can be in the form of an orthotopic neobladder, where the patient voids through their native urethra. And so we'll start with a vesicostomy. So this is a creation of a continent catheterizable stoma that allows for drainage of the bladder, and that's exactly what this patient has here. And so here is a catheter that is going into that stoma that is in the umbilicus, and umbilicus is often utilized for purposes of cosmesis. And it's used in patients whose bladders store adequately, but they don't empty well. And the stoma is created from patient's tissues. This can be in the form of an appendicovesicostomy, utilizing appendix to form the stoma. This is also known as a Mitrofanoff. And then it can also be a stoma can also be created from ileum, and this is an ileovesicostomy, and it's performed utilizing the Yang-Monti technique that I described as part of the ileal ureteral repair. And so here is a depiction of that vesicostomy. This is the Yang-Monti, whereas this is the appendicovesicostomy and harvesting that appendix. And oftentimes the bladder is brought into closer proximity to the abdominal wall, and then that catheterizable channel and stoma are formed from that native tissue. And so this is the appendicovesicostomy here. So the next form of diversion is a conduit, and so this is a incontinent diversion. It diverts urine directly from the patient's ureters to a storage appliance outside the patient's body via a stoma. So in other words, it drains into an ostomy bag. Indications for this procedure are diseased or absent bladder, typically after radical cystectomy for cancer. And patient selection is going to drive who gets this type of urinary diversion. And the reason for that is because this is essentially the simplest form of urinary diversion for a patient who no longer has their bladder. And so important parts of considerations for that patient are, do they have CKD or impaired renal function, where storing urine and not emptying and allowing the kidneys to drain could be a major problem for them. Patients who have poor vision or poor manual dexterity can have issues catheterizing, and so an orthotopic neobladder or a continent cutaneous diversion may not be a good option for those patients. Patients who have urethral disease would preclude a patient from having an orthotopic neobladder. Those who have had pelvic radiation, for whom a native urethra or other tissues may be deleterious in trying to divert the patient. Patients who have liver disease and aren't going to heal, and those who have poor compliance or other inability to maintain the continent diversion. One of the aspects of a patient's day-to-day living that's really important if they have, say, an orthotopic neobladder or a continent cutaneous diversion is adequate hydration. And the reason for that is that the bowel that is utilized to perform the diversion and is storing the urine will still produce mucus. And so if they are not adequately hydrated and they're not adequately diluting their urine and having large volumes of urine, they can get a lot of mucosa or mucus buildup, in those pouches. And this can cause problems with emptying, and it can also precipitate infection and things like that. So patients need to really be active participants in their health if we're going to consider a continent diversion. And so for those patients where we have doubts about their ability to do that, an incontinent approach may be the better option for them. And so here's how the conduit is created. And so there's a segment of bowel that is harvested from the ileum, and then the ureters are passed through this mesenteric window and anastomosed to that segment that acts as a conduit. And there are a couple different ways of doing the anastomosis. One is a Bricker, and that's what's being depicted here in A and B. And the other is a Wallace in C and D. Let's see. And looks like F is also a Wallace. And so what the difference there is that with the Bricker, the ureters are anastomosed to that conduit separately, whereas in the Wallace technique, the ureters are essentially anastomosed to each other, and then one anastomosis is created into the ileal conduit. Neither one is necessarily better than the other. They both can have their advantages and disadvantages. For instance, with the Bricker, you can have, I think there's higher rates of stricture, is what I was reading. But then with the Wallace, if there is a stricture or there's an issue with that anastomosis, you've dedicated both ureters and therefore both kidneys into that single channel. And so you can theoretically precipitate bilateral obstruction if there is an issue with that anastomosis. G and H are just means of trying to reduce reflux for these patients. And so that's the technique that's being depicted here, is essentially this tunneling of the ureter in order to avoid that. The next type of diversion I want to talk about is the continent cutaneous diversion. So this is where a continent pouch is constructed for the purpose of storing the patient's urine, and then it is drained via catheterizable stoma. And so this essentially bypasses both the bladder and the urethra. And these segments are typically made of, or these pouches are typically made of bowel. And there's many kinds. And depending on the segment of bowel that is utilized, the segment may have an intrinsic continence mechanism, or it may require construction of that continence mechanism by the surgeon. And so an example of one of these continent cutaneous diversions is an Indiana pouch. So it utilizes the entire right colon and then 10 centimeters of the terminal ileum. And the colon is detubularized, and then the ureters are implanted. And the ileocecal valve is reinforced with imbricating sutures, and this acts as a continence mechanism. And then the segment of the ileum is then used as a catheterizable channel after formation of a cutaneous stoma. And obviously that colon is utilized as the pouch storage device. And so here is an example of that, and it being brought to the skin surface, and then this catheterizable channel. And this is kind of in contrast to another popular, or what was previously popular form of continent cutaneous diversion, which was a Coke pouch. And the difference between a Coke pouch and an Indiana pouch is that the Coke pouch necessitates construction of that continent mechanism. And so it's a longer procedure, and that's why a lot of folks have moved away from doing a Coke pouch and have opted for something along the lines of an Indiana pouch, where there's a continence mechanism that is already partially created and tends to reduce the length of time for the operation. So the last form of diversion I want to talk about is an orthotopic neobladder. So this is where tissue, this utilizes tissue from another organ to construct a new bladder. The ureters are implanted into that neobladder, and the neobladder is then connected to the remnant of the patient's urethra. And the patient's external urethral sphincter provides the continent mechanism, and then the patient voids via the native urethra. And there's many styles and techniques that can be utilized for this. But again, patient selection is critical. So patients for whom this is, we're going to pursue this option, need to really be actively involved in their health. They need to be people that are going to follow up, that are going to take good care of themselves, that are really going to follow the advice of their urologists. They also need to be patients who, if need be, can emergently catheterize themselves if they are having difficulty emptying. And orthotopic neobladder has just recently hit the news. If in case you weren't aware, Deion Sanders, Coach Prime, actually had a radical cystectomy performed recently at the University of Colorado, and he received an orthotopic neobladder as his means of urinary diversion. So here's some of the techniques that can be utilized for orthotopic neobladder. So this is on the right here. This is a Studer approach, and so it's that aforementioned bowel segment is harvested, and then it's created. It's turned into this pouch with kind of this chimney looking aspect to it, and the ureters are plugged into that chimney, and then the patient's native urethra is anastomosed on this lower segment. Alternatively, you can perform this type of procedure where the bowel segment is kind of folded into sort of this W shape, kind of like a soccer ball, and the ureters are plugged into here. And then the patient's native urethra, of course, is anastomosed onto this lower segment. So, of course, there can be complications from these orthotopic neobladders. So you can have bowel and urine leaks, as well as bowel and urinary obstruction. You can have bowel and ureteral stenosis. Malabsorption can be a problem. Essentially, you create a short gut syndrome. These patients are prone to UTIs as well as pyelonephritis. They can form stones. You can have concomitant renal injury that occurs from inability to adequately drain. When bowel is used, it can precipitate a hyperchloremic metabolic acidosis due to aspects of absorption, because the bowel is absorbing electrolytes and metabolites the way that urothelium does not, a bowel will. So that can be a problem, and that can precipitate abnormal drug metabolism as well. You can also have recurrence of malignancy. This can be de novo, or a recurrence of the patient's cancer, essentially in that involved neobladder segment. And then you can also have stomal hernia, stenosis, and or necrosis of the patient's stoma. So all things to keep in mind. And here is a patient who unfortunately developed a leak and had a urinoma from the ileal conduit. So in summary, ureteral repair and bladder augmentation / diversion are critical elements to reconstructive urology. Basic principles of surgery, those being tension-free anastomosis and ensuring quality tissue and blood supply, is always a good first start to approaching these surgeries and surgical planning. Reconstructive urology is inherently creative, and there are a variety of techniques to performing procedures. And knowing what has been done and what's described in the literature and what is theoretically possible, I think, are really key elements. And that's what kind of precipitated this talk for me. I am continuously kind of blown away by different aspects of reconstructive urology, and I just go, oh wow, I didn't even know that was possible. And so that's why I wanted to bring this talk to you today, is just a means of kind of showing what has been done and what are things that we can think about doing when we encounter these patients who have had ureteral injuries or have had prior surgeries. And to that end, having a knowledge of these techniques can really help any urologist have a plan as to how to approach these types of injuries and or care for patients who may have had one of these surgeries previously. Case in point, we have a patient on the service downtown who received a urinary diversion with a continent cutaneous pouch many years ago, and a cystoplasty, and was kind of just came to our service. We weren't involved in her prior augmentation, but ended up being on our service due to complications from that. And we are tasked with caring for her. And that is a very real world example of how having an understanding of some of these principles of reconstructive urology can be really important. These are my references, and references continued. And I really thank you for your attention. this morning, and I'm happy to answer any questions.
Hey, Tommy, very nice talk, Tommy. Um, Tommy, the other thing worth highlighting is uh, the robotic surgery and the role of intracorporeal urinary diversion. That's rapidly evolving now and is being more widely used. And when it comes to orthotopic neobladders, we have choices. With increasing use of intracorporeal, people are leaning more towards Stewart than Hartmann pouch, which is the W pouch you were referring to. It's just a little less suturing and a little bit easier to do and saves some time. So people are adapting these techniques to minimally invasive approach.
Absolutely. And that's a great point, Dr. Balaji. Um, a lot of these surgeries, like many surgeries that we do, were initially started open. These techniques were conceived and conceptualized open, and now are gaining traction in through various minimally invasive techniques. And that was a whole different deal in and of itself, and is really fascinating, and is are excellent things to keep in mind, and are going to be critical to our education. There's no doubt about it.
Yeah, and then especially with the stapling technology with our current robotic systems, helps us as well. Before we had the technology, we had to use laparoscopic staplers. But now we have robotic staplers, which gives us better angle and so on, and a little bit easier to do. So,
Absolutely.
yeah. Yes, any other questions or comments for Tommy?
Tommy, it was an excellent talk. It's a broad topic. It's hard to go through that many potpourri items uh, in any more detail. And so you did a really good job taking on such a big subject.
Thank you, sir. I appreciate that.
Okay, if none else, we could stop here. Thank you again, Tommy. There's a lot of work. We appreciate it. Thank you.
Thank you, everybody. Hope you have a great day.
Thank you.